So this is less of a sort of a teaching talk and a little more of just like a story. The initial assignment was sort of how has the internal brace changed your return to play and your treatment of ankle instability. And I sort of changed the talk to how has the internal brace changed my practice. How has the internal brace changed my practice? And the answer is essentially, I'm a surgeon that thinks differently. Okay, and if you think about orthopedics, if you think about medicine, it's hard to get people to think differently. Okay, so we're taught principles and residency and fellowship and all that kind of stuff, but there are only certain people, certain times in your training that you actually started to think differently about something. It's not, maybe it's a paper you read, maybe it's a mentor that you worked with, but the internal brace has forced me to think differently. And so let's talk about two central concepts, tradition and routine. Okay, so tradition is the way things have been done for a long time, whereas routine is the way one typically does things, like on an individual basis. But they are not to be confused with the ways to maximize efficiency and effectiveness, right? Sometimes they have conflicting priorities. So on the one hand, we want to do what's comfortable, do what we're good at, right? But on the other hand, we want to do what achieves the best results. And whether that's with a surgical approach or planning your morning commute, like these are decisions that we make. And if we're going to kind of mitigate the differences between those, they require change. But change is something that occurs slowly. It's hard to make change happen. If we take an example from sort of the history of orthopedics, right? So in 1972, that was the year I was born, someone with a meniscal tear might have had, with mechanical symptoms without arthritis, they might have had an open, complete, or subtotal meniscectomy, which gave excellent pain relief, right? But in 2018, no one gets that, right? People get all arthroscopic, subtotal meniscectomies, or even sometimes meniscal repairs, and no one gets that all open surgery. So almost half a century later, did the disease change? I mean, of course it did not, right? And surgeons didn't grow tired of the procedure. What happened is that there were advances in arthroscopic techniques, and there were long-term studies that demonstrated accelerated degenerative changes in the knee. Right, if you look at a 40-year follow-up on adolescents who had meniscectomies, there was a 132-fold increase in the rate of total knee replacement. Now, I guarantee you, it's not in 2012 that the practice of open total meniscectomy was abandoned, right? It was well before that, right? So when was it that people actually stopped doing that? Right? How long after the data was available? And if you look through the data, it's actually difficult to figure out exactly, because just because something's published doesn't mean people's behavior changes quickly. We know it took a long time, but why did it take so long? So in the face of like what was data that was coming out suggesting that this wasn't the greatest procedure, why did it take a long time for people to adopt change in their practice? Well, unfortunately, there is a gap between research-based best clinical practices and what doctors actually do, okay? We behave as if we disseminate clinical research findings. This will eliminate this gap. But unfortunately, in order to make a real change, we need to think differently, okay? And regarding the internal brace, is there data? Yes, there is data. And so I am a surgeon that thinks differently. And so how is it that I think differently? Well, here's the internal brace, and I'm not here to tell you what the internal brace is. And my assumptions in this talk are, you know what the internal brace is, you know what it's made of, you know what its general applications are for, you know how to actually put it in, right? So the internal brace is essentially a check rein, right, with a high times zero strength, okay? So in thinking about that, I have started rethinking my surgeries and sort of contemplating the idea of like what actually needs a check rein and a time zero strength. Like in everything that I do, like is there an application for this? Does a high time zero strength change things for me in the way that it has changed things for me for Brostroms and other very common applications for the internal brace? There are numerous applications for the internal brace, the ATFL, deltoid, spring ligament, ATFL, even total ankle, and I'll go into that in just a minute. And the Brostrom is a very straightforward one, right? It's a very obvious improvement. My patients at 6 weeks looks like my patients used to look at 3 months. Before, when I would do a modified Brostrom, and you know, I changed with Roger Mann, and this was sort of chronic, like old dogma, and I love Roger Mann, and he's taught me many of the principles that sort of govern my surgical practice to this day. But we made patients in a short leg cast, 6 weeks non-weight bearing. And really, I started physical therapy at 2 weeks. And, a lot of these protocols, these accelerated protocols I've taken from Troy, who's shown, great improvements in athletic activity very early after internal brace. But what else? What else is it that we can do? So here's a case illustration, right? 46-year-old male Iraqi veteran, chronic ankle instability after an IDE blast. He has a little bit of a traumatic brain injury. He even uses a service dog to help him when he thinks he's going to fall. And so basically, this is a case where I used an internal brace and there's his incision, and this is him walking 4 weeks later. Right now, I don't have him jumping and all that kind of stuff, but this guy needed a service dog to keep his ankle stable. And with an internal brace giving me that confidence, it gives patients confidence, and it's really changed the way that I've done that procedure. But where else is this applicable? Well, in a subtle Lisfranc, I've started to use an internal brace, and why bother? Like, why can't you use a screw? Why can't you use a tightrope or something like that? Well, I'm pretty confident in the strength that it gives me that I've been able to even weight bear these patients, and that's a big deal for them, right? Surgery is a big inconvenience for patients who can't walk, who can't get to work, who can't go up steps. And so if you can safely change their ability to have surgery easier, then it's probably worth considering. When it comes to ankle replacement, and I do lots of ankle replacements, right? But I make my patients weight bearing as tolerated at 2 weeks. But if in the surgery I find that there is some deltoid laxity or there's some lateral ankle ligament laxity, I can easily tighten up those ligaments using an internal brace. It adds me an additional 5-minute procedure. But the important thing to me is it really doesn't change the way I handle their rehab and post-op protocols after surgery, which is a real advantage for me. What about even for cases where I'm not using the internal brace? Like, that sounds like a slide that shouldn't even be in an internal brace talk, but it is because I think a little differently about it, right? So when we talk about a peroneal tendon repair, whether it's a split tear or whether it's a tendon transfer, I think about how strong is that tendinous end-to-end, side-to-side repair. And if I'm confident in it, then I say, okay, well, the time zero strength is okay. I weight bear him as tolerated at 2 weeks in a boot. I start PT at 6 weeks. I don't keep him locked up. The tendons don't get stiff. And it's this specific example is an illustration of how this technology has forced me as a surgeon just to think differently, just to approach things differently. And I think that's great. So in summary, the internal brace has really changed my practice, not just because it makes the recovery from a Brostrom procedure easier, and it does do that, but I think differently. I think I have happier patients, it gives me confidence, and it's simple.